Hey, welcome to everyone who has been able to join us on this sunny Friday afternoon. Thank you for joining us. I'm very pleased to introduce Dr. Stephen Narod, who many of you may have met in the past if you've been a patient at Women's College Hospital, or you may have had the opportunity to interact with him at various conferences that we hold for patients. So as many of you know, Dr. Narod is a professor in the Dalla Lana School of Public Health at the University of Toronto. And he's also a senior scientist at Women's College Research Institute, where he is the director of the Hereditary Breast and Ovarian Cancer Clinic. So again, some of you may have seen him in clinic. I don't think I need to give a great introduction, but Dr. Narod really has shaped what we know about the management of women with an inherited predisposition to developing breast cancer. A lot of the seminal research papers that have come out in this area have been led by Dr. Narod and the team at Women's College. So he's going to present some of the more recent data on managing cancer risk in BRCA carriers after the age of 50. And I'll just remind you that we're going to leave plenty of time for questions at the end. I know there are always a lot of questions for Dr. Narod. So if you could please just enter your question into the Q&A button at the bottom of your screen. And then at the very end of the presentation, Dr. Kotsopoulos and I will relay some of those questions to Dr. Narod on your behalf so that everybody can benefit from the answers that he's able to share with us. So thank you for joining us, Dr. Narod, and I will turn it over to you.
Thanks, Kelly. Good afternoon, everybody. So I'm going to be presenting something old and something new, and I'm going to be reprising much of what's gone on in the last, I think, 30 years since I've been involved and where we are now and where we maybe hope to go. So I said in managing risk in carriers after 50, just to imply that even though we think this is a young women's disease, I often talk about it, that it still is something that carries on, I think, well into adulthood, certainly into the 70s, and that the risk period begins for breast cancer in the 20s and ovarian cancer in the 30s, but does it ever really get back to normal that we can forego, considering ourselves high risk survivors, et cetera? So I've been involved in this since identifying the breast cancer genes back in 1994, 95. But even before then, between 1987 and 1990, we started out in Lyon, France, with Henry Lynch, looking at families, looking at large families with multiple cases of breast cancer, leading to the discovery of the two genes, which we're going to talk about today, was BRCA1, first discovered, and shortly thereafter BRCA2. They are actually very similar, but there are a little bit of differences which we can emphasize today. And so when we started this study, I came to U of T in 1995 at the Women's College Hospital. We started collecting information on women with mutations, following them forward. You see that purple line? We started in 1995. We got all the way up to about 18,000 women enrolled in the study, of which about 10,000, not many maybe of you listeners, are being followed, asking questionnaires. These questionnaires are designed to try and answer some of these critical questions. You can see on the bottom, we talked about preventive studies, oophorectomy, mastectomy. That's very important. Surgical approach, but also we want to know about hormones. I think probably the most important question we could get about hormones is it safe to take hormone replacement therapy following removal of the ovaries? That is a preventive oophorectomy. And we've done some research on that, suggesting, yes, we should be able to safely offer estrogen without progesterone to manage menopause in young women who have gone through the menopause by surgery. Over the years, you can see in the green line, we've published up to 500 papers on these topics. So we're carrying on, and I hope the lines continue to grow. Right at this point, we've got some of our major papers are being submitted in press, will come out soon. Paper on tamoxifen prevention of breast cancer, a paper on oophorectomy, a paper on bilateral mastectomy, and the paper on MRI. These are all options for women, and I want to know which ones are associated with the best outcomes and, of course, side effects. The patients in the studies really come from all around the world. We see dots and red dots. Norway, Poland, the little red one in the middle of Europe, has given us a particularly large number of patients. We got patients from Israel, Italy, Portugal, Bahamas, small islands in the Caribbean, actually has the highest rate of mutations among the breast cancer patients of all. In Canada, about 3% of those women with breast cancer, young breast cancer, triple negative breast cancer, will have a mutation. In Israel, it's up to 10 or 12%. But in the Bahamas, we discovered 22% of new cases of breast cancer carry a mutation in BRCA1 or BRCA2. So it really varies a lot depending on the ethnicity and the composition of the country. Okay, so this has made this slide really recently. So I told you we've been following these women for 25 years. And in the 10,000 women that we're documenting, we're following every couple of years, we found, 10,083 subjects. There was 2,000 of them who developed breast cancer. We have more BRCA1 carriers, not breast cancer, any type of cancer. We have more BRCA1 in the study than BRCA2. So those numbers are not rates, are just number of cancers. But you can see our target cancers are on the top. What are we really trying to do? Well, we'd like to prevent all those cancers, but if we can't prevent them all, let's go after the ones that we can get at, which is pretty impressive because you'll notice breast cancer, half of so these are all cancers developed in the carriers, half of them being breast cancer. These ovarian cancers, 213, really are preventable by preventive surgery, but you have to know you have a mutation. In particular, there was many of these women who got ovarian cancer already had a diagnosis of breast cancer, probably had never got a genetic test. So they got a genetic test at the time of breast cancer diagnosis. They would have followed possibly the recommendation for oophorectomy and avoided that cancer. Ovarian cancer is more common in BRCA1 than BRCA2. The next thing, we have skin cancer. I don't know if it's related, it's a common cancer, but it was more common in BRCA2 than BRCA1. Melanoma is a more serious form of skin cancer where we do recommend screening for physical examination once a year for these women. It's higher in BRCA2 than BRCA1. You'll notice endometrial cancer or uterine cancer is relatively uncommon. There were 44 cases in 10,000 women, which may suggest something not to worry about. But on the other hand, if you would do a hysterectomy at the time of the oophorectomy, you could avoid those. My opinion, if it's possible to avoid, it's worth avoiding. And that goes with fallopian tube. So here we are looking at the overall range of cancers, and our goal is to get rid of the breast cancers, get rid of the ovarian cancers, get rid of the endometrial cancers and the fallopian tube cancers, and that would take us a long way. The other ones are luckily much more rare, but we don't have a really good way of preventing them. Now, peritoneal cancer is something we're working on. That's the cancer in the abdominal cavity after an oophorectomy. So 46 of our patients had their ovaries removed, ended up getting a peritoneal cancer lining the tract of the abdomen. That's about 2% of the patients. That's higher than we want, and we can't yet put that into the preventative category. We're looking at ways of doing it. But you can see if we concentrate on breast, ovary, endometrial, fallopian tube, and cervix, I mean, a hysterectomy would eliminate those cancers. We'd really be dealing with the great majority of the cancers. There's quite a bit of discussion about pancreatic cancer. Pancreatic cancer is a feature of BRCA1 and BRCA2. We've got 14 cases, much less than the good thing about it, it's rare. So 14 out of 10,000 women over 10 years. Not something to ignore, but we don't really have a way of, I'm not putting that into the preventive category yet. There's some evidence of screening, but currently in Ontario, we don't have a pancreatic cancer screening program. Do you see any other cancers there that you're of interest? You could be my guest to ask. I think the rest of those cancers, other than the ones I mentioned, are just random in that women got that weren't due to the mutation. So if we look carefully again, just to recap, the ones that are mutation related are breast cancer, ovarian cancer, melanoma, peritoneal cancer, fallopian tube cancer, and pancreatic cancer. There's some question whether endometrial cancer, which is relatively common, is part of the spectrum of these mutations. Some people say it is, some say it isn't. I say it may not be part of the spectrum of the mutations, but for women that take tamoxifen or women that take estrogen, there may be an increased risk based on the treatment rather than based on the gene. So moving forward, I just wanted to sort of emphasize, these are the patients in our study. I show for breast, I show for ovary. For BRCA1, I just want to mention, okay, so what's important for BRCA1? The peak age of diagnosis, the most common age of diagnosis, is from 36 to 40, which is obviously young. We do see it rarely before age 25. So what would be the ideal age if you're going to have a preventive mastectomy? We generally say somewhere around 30. Ideally, I mean, there is a, of the 5,600 cancers, there were 372 under the age of 30. So for those women who want to be particularly vigilant, one could recommend mastectomy at 25 for those who choose a surgical. All I can say is the earlier the oophorectomy, the more cancers you prevent. But most women on average are diagnosed. See, this is a peak age, but most women don't get their genetic testing until their 40s, at which time, nearly half of the cancers have been diagnosed. So that becomes, and as you get older, the cancers never quite disappear. We can see the risk is elevated until age 70, but the number of cancers, the risk of getting cancer diminishes quite rapidly. So at this, over age 60, we generally recommend to go with an MRI or screening rather than mastectomy. Really, it's the patient's decision. I just think numbers like this help decide, looking at the numbers and what are the chances. Overall, what are the chances of getting cancer if you're 25? 70%. So these add up to 70%. And another way of looking at it, age 50, we followed women from age 50 to 75. So even though 70% of the risk of cancer is lifetime, between age 50 and 75, the risk of breast cancer for BRCA1 was 41%. So that certainly is still a significant number. Some may choose screening, some may choose surgery. Now for BRCA2, the average age is a little older. So we jumped from 36 to 40. The average age is 45 to 50, 41 to 45. The distribution is pretty wide though. And you can see it's a little flatter. The risk is just about the same at 70%. The average age of onset, a little bit older. So what's the risk of, so I said what was it for BRCA1 was 41%. So for BRCA2 after 50 was 45%, which might be surprising that the risk for a 50-year-old, the risk of BRCA2 is a little bit higher than BRCA1. That, as I said before, those ages of diagnosis are shifted to the right. So more of a higher percentage of the BRCA2s are diagnosed after age 50 than the BRCA ones. Now let's look at ovarian cancer, which is real important. 2,000 women with ovarian cancer, BRCA1, peak age 46 to 50, continues till age 75. We recommend the oophorectomy between 30 and 35. You can see why. Under 30, there are rare cases. But if we do the oophorectomy at 30 to 35, we'll be preventing the great majority of cases. After 50, age 30% would get ovarian cancer if their ovaries were intact. For BRCA2, now you can see this is quite a bit older. It's very interesting. The peak age for getting ovarian cancer at BRCA2 was 56 to 60, which is the same as the general population. It's not a young woman's disease, it's a woman average age. This is the same distribution you would get in the general public. The BRCA1 is young onset. And what we like about BRCA2, now there's never any guarantees, but there were very, very few cancers diagnosed under age 40. You can see the jump hits at 40 to 45. We recommend the oophorectomy be done at age 40 for this reason. The other thing about BRCA2 that's very notable is over age 60, the risk is still pretty high. The risk stays pretty high all the way from 60 to 75. So if we certainly, for a 65-year-old woman who is healthy and is discovered to have a BRCA2 mutation, she's still a candidate for oophorectomy, preventive surgery. We do it at Women's College Hospital as an outpatient department. We have excellent surgeons, Michelle Jacobson and others that will do that as a same-day surgery. But we just want to make sure people don't get the impression that, well, I'm already 65, my chance of getting ovarian cancer is not high enough to rate this prevention. BRCA2 ovary is notable for the late age of onset, particularly the continued increased risk over age 60 or age 65. So how do we reduce the risks? We talk about getting cancer, that's the easy part. The hard part is not getting cancer. Essentially, you have two options. We have what we call the preventive option, which is trying not to get cancer in the first place. We have the screening option, which is to find it early and hope that when you find it early that you get it at a curable stage. We'll talk more about that for breast cancer, just to bring you up to date. But for ovarian cancer, we've done a large study in Poland, and we didn't find really that the screening was that effective. We screen the people every year with ultrasound and CA-125. And there was a slight reduction in the mortality. There was a little bit of benefit, but the number of women who died of ovarian cancer, of those that were detected by screening, was really not acceptable to consider it an alternative to prevention. Well, the main way of preventing surgery I talked to you about that reduces the risk of ovarian cancer is the preventive surgery, preventive salpingo-ostomy, which means you should have your ovaries and your fallopian tubes removed, because those are the site of cancer. It reduces the risk by 87%. I think it's probably more. Why is it not 100%? Well, I mentioned before we had those cases of peritoneal cancer. So about 2% of the women get peritoneal cancer after having their ovaries removed, which is some higher than we'd like, and we're working on it. Should you have a hysterectomy? Now, it's not standard recommendation. It's a little bit more aggressive surgery. It will depend on the discussion with the surgeon, but to me, you know, if we can try and reduce as many cancers on that list as possible, I would go for it. And the hysterectomy will reduce the rare chance, but we saw 44 cases of endometrial cancer and 8 cases of cervical cancer. To my understanding, the surgery is 100% effective in reducing the risk of those cancers. Furthermore, when you don't have a uterus, you have more options for hormones. I mean, tamoxifen, for example. Are there other options? Yes, there are other options, but we don't really think they're competitive with the oophorectomy. In other words, we will not say to a woman, you have an option of oophorectomy or breastfeeding. We would like, we encourage breastfeeding. Ovarian cancer reduces the risk by 23% when you're breastfeeding. Tubal ligation does seem to reduce the risk of ovarian cancers in BRCA1. We wrote that paper 20 years ago. And oral contraceptives are quite useful. They reduce the risk of cancer by 56%. Most women take them. However, I do think it's useful, particularly for women who may wish to defer the oophorectomy beyond age 35 to take oral contraceptives. I don't think, I think these are options, and I think it's good to know. I don't think they're really rational alternatives to the surgery, which is really the mainstay, the gold standard of preventing ovarian cancer. So let's talk about breast cancer. Well, the gold standard, but what I mean by that is the highest level of protection offered by anything is bilateral mastectomy, which certainly seems to impact, the risk. We would be surprised if it didn't work, but it reduces the risk of breast cancer by about 95%. Now, when I say the gold standard, I don't mean everybody should get it. It's certainly an individual choice, one that should be made, taken into consideration the patient's preferences, discussing with the genetic counselor, discussing with the surgeon, and discussing, if they wish, the option of a reconstructive surgery. In Women's College Hospital, I think the majority of women, probably 80%, who have a bilateral mastectomy will go for one form of reconstructive surgeon to reconstruct the breast following surgery. There are a lot of women now, particularly in the United States, which I've run into and discussed with, who say that that's not necessary and would prefer to, would they say, go flat. Certainly that's their choice. And so I'm particularly, my job is to make sure that we got the numbers right, and that we refer patients to the right people, and that the people who want genetic counseling and would benefit from it get genetic counseling, get genetic testing, get the information, and then make an informed decision. We have seen in our study 5 women who did have bilateral mastectomy and went on to develop breast cancer. It's relatively rare, but it's a possibility, and says it's not perfect. We also had, I think, 15 women. This is something to be aware of. 15 women who had a bilateral mastectomy in our study had breast cancer discovered in the breast tissue at the time of the mastectomy. So it went from being a preventive surgery to essentially a treatment. None of those women died, which is really a good thing. So it's kind of like a early detection. But I do think, when I look at the numbers, that if a woman is going to be going for a bilateral preventive mastectomy, she should have an MRI examination first, just to make sure that the surgeon's aware if there may be cancer there in the first place. Right now in Canada, I think Kelly may know better, but I think about half of our patients opt for bilateral mastectomy, and the other half opt for screening with MRI. Now, oophorectomy, we initially thought would reduce the risk of breast cancer. Our recent studies with Joanne and others show we really didn't manage to reduce the risk of breast cancer. Oophorectomy reduces the risk of ovarian cancer, fallopian cancer, and has actually a pretty good effect on all-cause mortality, but doesn't seem now to prevent breast cancer. Tamoxifen is a drug that was designed way back in the 1980s as a preventive drug. It's used, of course, to treat women with ER-positive breast cancer, but it's also the only drug licensed for prevention of cancer in young women premenopausal. We have very few women choose to take it, which is an interesting question. We don't have enough data in the BRCA1 to really say it's effective. In the general population, it does seem to reduce the risk of ER-positive breast cancer. It reduces the risk of DCIS, but it's never been shown to reduce the risk of dying of breast cancer. Interestingly, in the studies, it reduced the number of cancers by about 50%, but it didn't reduce the number of women who died of cancer. Now, MRI, I mean, the goal is, it's a screening test. What does that mean? I mean, if you have a 70% chance of having breast cancer over your lifetime, you can reduce that with the mastectomy, maybe to 2 or 3%. But having an MRI won't reduce the risk of getting breast cancer. The goal is to reduce the chance of dying of breast cancer. And it does seem to be quite effective. So we have some good news on that score. This is our last, this is a bit old. We've been looking at tamoxifen use. So between 50 and 75, the women who had tamoxifen, BRCA 1 and 2, they did have a much lower risk of getting breast cancer developing, but there was only 50 women who took tamoxifen, so it's too early to say if that were to be held out. Mind you, if this were to hold out, reducing the risk from 44% to 23% would be a successful and a useful drug, but we're too early to really say it works. We do have a paper coming out on tamoxifen that was just accepted this week, the first preventive paper on tamoxifen. In that study, it showed it reduced the risk of breast cancer by about 30%, which isn't nothing, but it was not quite statistically significant. So now we're, excuse me, showing some theoretical stuff. This is what we did with Kelly. We took all the patients in our database and followed them. This is all types of cancers, all the cancers I showed on that list. Breast, ovary, fallopian, leukemia, so they're all included. So this is what the risk of women who's 50 faces a risk of getting any cancer, some related to the gene, some just by chance, who does not have preventive measure. What I mean by preventive measure, preventive oophorectomy and a preventive mastectomy. Has an 80% chance of getting breast cancer between 50 and 75, most of which are breast, ovarian, and fallopian cancers. Now, then we took the same group of women, these are different women from the same study, and we had looked at those who had both their breasts removed and their ovaries removed, and followed them from age 50 to 70. For all cancers, leukemia, brain tumor, everything included, the risk went from to 9%. I think this is about the most incredible story I think we've been able to tell after 25 years in the business, that there no preventive measures 80%, preventive measures 9%. Now I wish we didn't have to do surgery. I wish we could find better ways of screening. I wish we could find better ways of preventive medications. I'm just saying this is where we are now, and this is sort of the standard for we have to challenge in order to do better. So MRI is actually pretty good. Surprisingly, we just finished and submitted the MRI paper, and this is basically the gist of it. When we divided those women who had both breasts intact, these women didn't have a bilateral mastectomy, and we followed them for 20 years. Of the ones that 1,756 women were in an MRI program, and 14 died of breast cancer. So 14 died of breast cancer in 20 years out of 1,756. What that means is the 20-year rate of dying of breast cancer was 3.2% after the first MRI. I don't know if they had MRIs every year for 20 years. I just know they had one. And in the 20 years that followed that one MRI, there was a 3.2% chance of dying of breast cancer. which to me makes this a rational alternative to the mastectomy. In the mastectomy group, it was like 1%. Now, the no MRI group did, as expected, much less well. For them, there are 21 deaths from breast cancer in fewer than half the subjects. And if you see, that means at the end of the day in the green line, within 20 years, those women who never had an MRI, 15% of them died of breast cancer. That I consider unacceptable. So let's take that off. Now, those women may have regular mammograms. Let's take that off the table, doing nothing. So we can focus our discussion on MRI versus mastectomy. Another way of looking at the data, when we looked at all the people who didn't have an MRI on the left side, their annual risk of dying was 4, or the 10-year risk of dying was 4%. After an MRI, the annual risk of dying was 0.1%, 1 in 100. The 10-year risk of dying would be 1%. So, we really saw a dramatic reduction of 0.4% per year, which is 4 in 1,000 per year, to 1 in 1,000 per year. I find this study really fascinating, possibly too good to be true, that the MRI is so effective. And remember, we're comparing our group to women who didn't have an MRI, but 80% of them were followed by mammograms. So how does that compare to mastectomy? Actually, it's kind of interesting. So in this woman, we compared women with now we're comparing women with mastectomy, but their breasts removed, to women who retained their breasts but had an MRI. And so when we looked at that, you can see on the left is incidence. So they had a breast, so incidence means what's the risk? Well, 20 years, 29% of the women got breast cancer who had MRI, 2.5% of the women got a breast cancer after the mastectomy, or at the time of the mastectomy. So you can see a huge drop in the risk of cancer with the mastectomy compared to the MRI. It dropped from 29% to 2%. But we look at the mortality, the chance of dying at 20 years, the reduction is a bit less. Remember, I just said 3.2% of the MRI patients died of breast cancer at 20 years. In the mastectomy group, it was 1%. In terms of a relative reduction, that's huge. I mean, a third as many died. We cut the number of deaths by 2/3. But in the absolute risk, the difference was 2%. So, I mean, I think it's important that, how to interpret these numbers. These numbers can lead one to choose whether or not to go for screening, whether or not to go for mastectomy. I also should say, maybe a topic of discussion, that in the MRI study, about 20% of the women, after starting in the MRIs, jumped ship, more or less, or decided no longer to go with the annual MRIs and went for the mastectomy. So 1 in 5 of the women started MRIs annually, ended up having both breasts removed. I think maybe they were not happy with the annual MRI, and the anxiety, and they decided after 1 or more 10 years that the mastectomy would be the best choice for them, because realistically, then you're no longer in the doctor's care. I mean, after oophorectomy and mastectomy, there are some follow-ups we do, but it's very little. While you have your ovaries and your breasts, you're certainly a patient at high risk, and we follow you very closely for screening, etc. After the surgery, most of the focus shifts to non-cancer outcomes. We're very concerned about bone loss. We have to make sure, because young onset oophorectomy reduces bone loss, so that's something we follow. We follow quality of life due to surgical menopause, offering hormones where we can, offering other options where you take hormones. And there are other quality of life issues. We are now exploring with Joanne, hopefully continuing this study. Lots of our patients are getting older. So what happens once they hit 60? What happens to the cancer risk? What happens to the other things? Do they lose any kind of memory and attention? Do they lose their quality of life? There's an increased risk of heart disease, etc. So there's the bottom line, but that doesn't mean we're finished. There's plenty more to do. I think. Okay, so this one, we'll get back to that. Now, what's the screen project? The screen project is a siding thing, but I think something we could really be proud of here at Women's College Hospital. Mohammed Akbari, Kelly, and Joanne and I set out on this, I don't know, maybe 8 years ago, trying to say to the public, listen, if you want to have a genetic test, you should be in a position to have one. Certainly, genetic testing is offered by the public health system in Ontario and the other provinces, but you have to be referred from a geneticist to you have to be referred from a doctor to a geneticist. You may not get an appointment for months. You may not be eligible for testing. It may take a while. I'm not saying that's not a good program, but I'm just saying we didn't, when people were told, no, you don't qualify for genetic testing, you can't have a genetic test. We thought, well, those people should at least have the option of getting the test privately, paying for it. And today it's been very successful. So we have an online, I don't know if you guys know it, we have an online site here at Women's College Hospital. Everybody can refer newly diagnosed breast cancers, can refer people anywhere in Canada over the age of 18, whether they have a family history or not, whether they have a personal history or not. They can sign up and they will get a genetic test result. They're mailed a spit kit, little tube you spit in, and return it to the laboratory in the United States. The result goes both to me and to the patient within about 2 weeks. It's picking up speed. More and more people are aware of it. In fact, in the last year, we tested more patients through the screen project than we did in-house through our genetic counseling and referral patients. And I think it should be something people should be aware of. We haven't really had much energy behind or the resources to market this and to advertise. But I think word of mouth is bringing it around. So I think, anybody should know that if they're not offered genetic testing, if their lineup is too long to get into the counselor, if they're too far away, and as long as you live in Canada, you can get a genetic test. The current cost, I think, is $250 US. And finishing up with that, well, let's just go back a bit. So where are the bottom line? So what we want to go forward, where is our trajectory taking us? Well, the first thing we like to know, that thing about the 49 peritoneal cancers is too high. We got to find a way of avoiding it, whether it's contraceptives, whether there's some other way of getting at reducing the risk of peritoneal cancer after ovarian cancer is a priority. I think making sure we match the right hormones to the right women, particularly for women who have an early menopause. If I go around recommending menopause at age 35, I better have a good way of helping out that woman and her quality of life, sleep disturbances, sexuality, hot flashes, vaginal discharge, mood disturbance, etc. Which hormones are the best suited for her, which will relieve the quality of life, but won't increase the risk of any cancer. I think questions about long-term effects of BRCA1, long-term effects of the early menopause on, later adult diseases, heart disease, etc. We have to be aware of other consequences. Ideally, in an ideal world, we would do a study that to know we think we have a drug that will prevent breast cancer. We think it's the way best to compete with preventive mastectomy. We think there's a possibility that a drug denosumab could be used as a reduction in the risk of breast cancer to the extent where it can be competitive as mastectomy. However, that's a big challenge. The study isn't a challenge, but we've been having a tremendous amount of difficulty in generating the resources to put that study together. But I would tell you in 2023, there's only one drug that is available. Remember I said the only drug the only drug approved for preventing cancer in women under 50 in Canada is tamoxifen. We want to make it 2. It's an enormous challenge to add a drug for prevention because of all the concerns, et cetera. But I think that's on our radar. It's our goal. And our other study, which we're starting to collect now, is about the treatment of breast cancer, which is essentially for the women who develop breast cancer, who do have a BRCA1 and BRCA2 mutation. What's the best treatment to offer them? Surgically, radiation, and particularly the effects of oophorectomy on survival, and the particular which chemotherapy is the best. That's studies we're starting. We started last year. It's going quite well. We've accumulated already 2,500 patients to the study. That's 2,500 women with breast cancer and a BRCA1 mutation. And now we're trying to expand that to 5,000. And hopefully that will be finished by the end of this year to really know, to reduce mortality, not just by preventing cancer, not just by screening for cancer, but by having the optimum treatments and therapies as well. And that's keeping us all busy. So we got a ton of collaborators. So the list changes, but I think this is pretty current. Interesting. So let's say Poland, my dear friend Jacek Gronwald, Jan Lubitsky, Czerek Sabowski, Thomas Zarsky. I've been working with those guys for 20 years, and almost 5,000 of the patients in that registry come from Poland. And I'm visiting there tomorrow. I'm going to be at this time. I'll be on the way to the airport to go to Poland for 2 weeks to work with them. We have wonderful friends in Europe, in Austria, in Norway, particularly in Italy. We've become very close with the group in Milan, in their Monza, by Robert Fruschio. And I'm very proud and excited to say, yesterday, me and Joanna Kelly bought tickets. It's not all hard work, but we bought tickets to go visit Monza for 4 days. We will be spending 1 day with the patients that they have BRCA1 and 2 mutations, and 1 day with all the doctors in the Milan region. They're going to come and hear us talk everything we know about breast cancer, BRCA1 and 2. So that's 2 things to look forward to. And then third one will be in Israel in October. Plenty of people here in Canada. We can thank particularly close relationship with Raymond Kim and the guys over at Princess Margaret Hospital. Good relationship, 25 years with little folks at McGill. United States, Henry Lynch started this out with me back in 1987. Should show that picture. Unfortunately, he died about 4 years ago. But we have plenty of collaborators that we continue to work with. Hopefully, will be more. And if anybody is there that is with a mutation, wants to be part of this study and isn't signed up, we would be very grateful for an email. I have no idea what time it is.
Yeah, okay. So Dr. Narod, thank you. Good timing to stop. So we have 15 minutes for questions, and we have quite a few questions that we want to navigate through. So thank you for a really comprehensive and great overview of what the team with your leadership has accomplished over the past few decades. We still have a lot of work to do, I think. So we're going to start with the questions that have been posted. There are some questions on frequency of MRI imaging, which I think is an easy place to start for you. The frequency of imaging for someone in their mid-40s.
Well, I mean, we don't really have, the University of Chicago is starting a program where they recommend it every 6 months. The national guidelines and Ontario guidelines recommend it every 1 year. Certainly at this point, I would consider 1 year to be adequate. The University of Chicago has Kumi Alapati and their radiologists have been really focused on this idea that you should do it every 6 months for BRCA1, every year for BRCA2. I think that study may be getting under the ground. I personally, when we saw that reduction in mortality, that was at 1 year imaging, right? 1 year imaging, we dropped the mortality from like 12% to 3%. I'm not in a position to say, well, if it works at 1 year, let's do it more often. I wouldn't do it less than 1 year.
But right now, standard of care for mutation carriers is once a year.
Yeah, I go from age 30 to age 70,
Right.
once a year.
Thank you.
Dr. Narod, there's a question on the age of oophorectomy, and I think it's something that many women want to know the answer to in terms of how long can you wait to have your ovaries out? So if you're a BRCA2 carrier, you talked today about having oophorectomy at the age of 40. Do you think you can wait to 45 or 50?
I wouldn't wait to 50. You could wait to 45. I mean, we can look back.
You want to go back to that slide to show the ages of onset of ovarian cancer? Because I think that the visual sometimes helps women
Why not?
know
Why
where.
are we going BRCA1 and BRCA2?
BRCA2.
BRCA2.
Yeah. So you can see from this graph the ages.
You can include the 19 that developed disease before age 40, right? Maybe that's where we can start. How many women develop cancer under age 41 at the time of surgery, correct?
Yeah, so 41 would be the earliest.
Mhm.
The question is 41 or 45. It's your call. It's your decision, patients. I want you. What would be the chance of developing ovarian cancer between 41 and 45? I would say 2%. I can get that. 2%, is that a number worth taking? 2% chance you'll get it between 40 and 45.
Compared to 1.4 in the general population.
No, I'm talking about in a 5-year interval.
Yeah.
Compared to 0 in the general population.
This visual is helpful, though, I think, for women. So you have to decide what you're comfortable with as well in terms of risk. So by just looking at the number of cases of
But it
ovarian
does
cancer
just
by
point
age.
out it's somewhere between 41 and 50, 41 and 45. 46 is 50 is too late. I mean, those numbers are jumping. But I didn't mention tubes only surgery. Did anybody ask that question?
Yeah, actually, I was just going to ask you that one because someone brought up a really interesting scenario. I won't give too much of the details, but someone who had a diagnosis of breast cancer, so had a double mastectomy, then removed the ovaries, but it seems like the tubes were not removed. Is there a chance that cancer could still occur here 6 years later after surgery?
That's a specific case. Women breast cancer, what age?
60.
So she had breast cancer at age 60. She has a BRCA1 mutation.
2, BRCA2. She had a double mastectomy
and
followed
an
by
oophorectomy.
oophorectomy without fallopian tube removal.
And how do you know that? The surgeon said he left the tubes.
That might be a discussion too, to go back to confirm that the tubes were left, because that's not really what's generally
Not very
happening
likely.
in clinical practice now.
That's certainly not standard practice. I think they could did they remove the uterus?
Well, we don't have that detail right now, but I think you can maybe allude to the fact that we know that a subset of cancers are actually arising in the fallopian tubes, and that's why women undergoing oophorectomy also
The
have.
standard recommendation would be to remove the tubes and the ovaries. If someone didn't remove the tubes, is it worth going back for a second operation and removing the tubes? Tough question.
No, I think definitely it's a very easy surgery for someone to perform. I'm not sure.
It'll be fine. No, it's kind of hard to comment on individual cases.
Yeah, so we're going to try not to think about those individual cases, but there's a good question here too, and I think there is some confusion out there about whether or not risk-reducing oophorectomy reduces the risk of breast cancer. So years ago, we did say that it did reduce the risk of breast cancer. Can you comment on some of the more recent research, Dr. Narod?
Yeah, there were a lot of studies on that. The first studies were really case control studies where they compared people with and without breast cancer, and they found that more women without breast cancer had an oophorectomy. So I think those were kind of a bias. The last three studies, which was one from Netherlands, our study, and one from the gynecology oncology group in the United States, showed it didn't affect the risk of breast cancer. There's still some question. There's in one of our data sets, we do see a little effect, but I think the current my best estimate is it does not reduce the risk of breast cancer. There's a possibility it does, but to a small extent, but not to a meaningful extent. It's a tough question, and certainly there was many years it was promoted, the idea that it did, and was the idea that it doesn't, which is our current position, has been kind of slow to adopt, and a lot of people are still citing the early papers which show it prevents it.
Okay, thank you. So there's a very important question on hormone replacement therapy and taking HRT. So again, we're just going to assume this is someone with 2 breast intacts who is perimenopausal. So what do we know about HRT and breast cancer and ovarian cancer risk in this population?
Okay, well, if the person's perimenopausal, I wouldn't want to be spending I'd be spending more time discussing the oophorectomy than the hormone replacement therapy. Like the question, does HRT increase the risk of ovarian cancer? You and me have looked at that. It looks like there might be a slight bump there. Not high, but it may be a slight bump increasing the risk. However, if you're perimenopausal with mutation, I'm assuming, then we would have more discussion about the preventive ovarian surgery than the hormones. If you're perimenopausal with 2 breasts intact, now if you have breast cancer, which this one doesn't, we don't offer hormone replacement therapy, which makes it tough. If you don't have breast cancer, then we have the options. The main options, I'm not an expert on menopause, but we have plenty of them around, would be estrogen alone or a estrogen progesterone combination. The progesterone can be delivered orally by patch or by injection. The estrogen can be delivered orally or by vaginal suppository, I think.
So it's
The
complicated.
estrogen progesterone combination does seem to increase the risk of breast cancer. I would avoid it. If the woman has had a preventive mastectomy, she would be eligible for estrogen progesterone. Generally, we avoid giving estrogen alone because it increases the risk of endometrial cancer. Okay, generally, the reason to give progesterone is if you just give estrogen without progesterone, you increase the risk of endometrial cancer by a bit. Having said that, there weren't that many endometrial cancers, and there's a hell of a lot of breast cancers. The doctors won't give estrogen alone. That's why I sometimes think it's good to have the hysterectomy. So if you don't have a risk of endometrial cancer, then you're fine to have estrogen alone. However, if you had a mastectomy, then you can have estrogen and progesterone. It's kind of complicated. You got to think of the risk of breast cancer, the risk of ovarian cancer, and the risk of endometrial cancer. All 3 of them play in. In fact, we just wrote an editorial about that and submitted it to JAMA Oncology, me and Joanne, calling, I think, what would we call it? Hormone replacement therapy for high-risk women, time for a personalized medicine approach. So it's really individual. You have, there are now 3 cancers to think of: breast, ovary, and endometrial, all of them influenced by hormones in different directions. So we got to find a balance.
And that's thinking of a woman who's unaffected. So women who have had a personal history of cancer, that makes it even more complex because hormones are not indicated. So there's other approaches.
Yeah, well, one of our study goals in the treatment study is to see if that makes a difference. Generally, the women don't get prescribed estrogens or progesterones by their oncologist, but they go back to the general practitioner. And they feel if it's negative cancer and it's been a few years since diagnosis, and they're suffering from menopause, they could prescribe it. So we do have a few hundred women in the study who had breast cancer and took on hormone replacement therapy. It's going to take a few years to put that data together to see if it was safe or if it had an adverse effect.
Okay, thank you. I think that we've run out of time. There are a couple of questions about other genes like POLB2 and ATM. And we are starting to collect data on women with these other mutations in these other genes, because we still have a lot of work to do to catch up with what we know in BRCA1 and BRCA2. So we are starting to collect
Well, I
that
can look through these questions quickly and answer them if you want.
I think we've addressed most of them, but you can see if we missed any.
POLB2 will be a subject of another talk. We've done it, but it's a whole other world. Oophorectomy. Yes, if you breastfeed and take the pill, it reduces your risk more than just doing one. Metformin, there was a study used to prevent breast cancer treatment, and it was negative. It didn't work. IM46, get MRI screening once a year. Is there a cost for the screen test? Yes, it's $250. Hormonal IUDs. That's $159, I don't know.
We're going to be looking at that.
MYH gene mutations are concerned. ATM mutations are a concern. MUTYH are not a concern. We test for them. We find the results all the time. That's our most common finding in a gene called MUTYH. It's just one of those genes. ATM, if you find a mutation, the risk is high and needs to be seen by a counselor. Okay.
So thank you, Dr. Narod, for a wonderful presentation. A lot of great questions that help inform our research moving forward also. And so I guess I'm the speaker next session. It's our final session of the year before we break for summer. And I'll be talking more about reproductive factors in cancer and high-risk individuals. So thank you again for attending and wishing you a great weekend.
Thanks, everybody.